For those of you who don't know me, my name is Chad. I have a master's in business, which is just something fun I get to say. I actually spent quite a bit of years in education, the financial sector, and eventually, on accident, ended up in dental. It was a really fun time, and through that, we also decided to go into dental sleep medicine. It's where I met Michael Cohen and eventually became a sleep coach here at Awaken to Sleep. This is my beautiful family, my amazing, wonderful wife, my beautiful 3-month-old daughter, and my 2 puppies. That's my niece in the background, which she's cool too, but not the subject matter. So, 2 dogs, 1 child, 1 beautiful wife, and just a lot of adventures to go. I am men of faith. I am a student of life, and uh, I'm also what I like to call a recovering moderate apneic. Now, I like to share this because it's really going to play a role in our sleep conversation. The punchline is that while I worked at a dental practice, I was missed. At the time, I was a buck 35 soaking wet. I 5'10, relatively good shape. I talked to the owner of the practice when I was starting to talk to this company, Awaken to Sleep, and he said, "Well, why would you take a home sleep test? Look at you. All we need to do is give you a snore guard, a non-adjustable appliance, boil and bite, chair side appliance, and you'll stop snoring. It won't be a problem." And I didn't know what I know now, but the reality was, I come to find out about a year later that I had moderate sleep apnea. I stopped breathing 23 times an hour in my sleep. And it's that fact that makes me so passionate about talking about screening. It's why I get to be the one to work with you and your teams to get these results. We'll talk about those results in just a moment. Had I gone undiagnosed, statistically, I would have lost 10 years of my life. Not coupled with the increased risk of dying from things like drowsy driving, which I had done frequently, or a variety of different risky things that happens when you have sleep apnea. Needless to say, had I not been tested for sleep apnea, treated for sleep apnea, I wouldn't have my beautiful family here that I have today. Because of the home sleep test I did through Awaken to Sleep at the time, it's just protocol. All of our staff have to test. We don't sell tests, but we have tests for events, things like that. I had surgery. I had an appliance. I had a CPAP. I've done it all. My apnea went from 23 to 3. I got married, gained a couple pounds. I'm back up at a mild apneic level. And actually, my appliance is right here. I'll show you in office today. So with that, let's get into how high-performing practices do screen for sleep apnea. Just so you know, not all practices start off as high-performing. Here, we look at a practice, same metrics. These are metrics that we provide in coaching, where we look at the patients you see every day, look at how many you screen and how many you don't, so we can talk to the team about what's going on. When they first started screening for sleep, they were only screening 42% of their patients, 43% of their patients, if you want to round up. 43%. That means out of 10 patients they saw, they only talked about sleep and airway half the time, 5 out of 10 patients. Within 1 month, this was April of the year, the next month being May, we got them all the way up to 88%. So the number one thing you've got to do is start tracking this so you can hold your team accountable. You and I know, having worked in a dental practice, that it gets really crazy busy. It gets so crazy busy that sometimes our hair is on fire and we miss the conversation. And that's actually okay. But what isn't okay is thinking we've talked to all of our patients, but only ever having talked to half of them. And that's what tracking does for us. This training is the almost exact training. I've updated it a little bit, upgraded a little bit, that helped this practice go from 43% all the way up to 88% of their patients being screened. So this is for you if you want to be screening more of your patients, or even helping other offices screen and showing them a couple different steps. Why is screening important? Well, it's the first step in the process. We have to identify patients who are at risk for an airway concern. Identify patients who are at risk for an airway concern. From there, we have to determine the presence and severity of the condition in a step called assessment. And then, when clinically appropriate and when indicated by a sleep physician, we need to treat those patients with an oral appliance. Inside of this, it is with a humongous opportunity of dental practices to screen your patients. You see patients more frequently than any other healthcare provider. You have a relationship and an opportunity to speak into their lives that most doctors don't have. You see them more frequently, you have deeper relationships, and as we'll talk about later this evening, there are a variety of intraoral signs and symptoms that you see every single day that can be indicative or really indicate that there's an airway problem. Now, you might notice that I've stopped saying sleep apnea. This is important. This is my first verbiage tip of the night for you. If you ask 10 people if they have sleep apnea, 9 of them will say no, simply because you use the words sleep apnea. The phrase that we jokingly say with some pretty heavy sarcasm is, how many patients, or no one has sleep apnea, just ask them. Everyone thinks that if their neck isn't X amount of big, or if they don't feel like crap, or they're not a certain amount of weight, that they just don't have it. And that's not correct. And so we always talk about their airway health, because their airway is important, and everyone knows that. If you do have questions, make sure to put them in the question and answer. I will try to get to everyone's questions, but we'll probably save those for the end of the night. So that is the process. That's why screening is so critical and so important. But the next question is, I get it, screening is important, but should dentists really be screening? Well, the answer is absolutely. The American Dental Association in 2017 made it very public that dentists and dental professionals should be screening for sleep-related breathing disorders. Notice they did not say sleep apnea, but a broader spectrum of concern, sleep-related breathing disorders. So for patients who are having breathing disorders, we need to be having conversations with them. This is a recommendation on a national level. Whether or not you test them, whether or not you treat them, it doesn't matter. You are supposed to be screening for them. And so we're going to be walking through the screening portion, how do we find them, how do we talk to them workflow tonight. This is our workflow document. It's also the first document that you get to download. Pull out your phone, scan the QR code, and you will be able to download this document on a piece of paper for your team. Let's walk through it real quick. One, patients enter the office, they come and update the medical history. From there, our front office team needs to say, hey, there is a concern on here. We'll talk about what indicates a concern in just a moment. If there is a concern, then we want to note that in our chart. If you're using paper route sheets, you can write the words airway or AI, not artificial intelligence, but airway on the corner of the route sheet. And then when you give that patient to hygiene, make sure to point it out to them. Or if it's in the system as a notification, you're off to the races. From there, hygiene is going to perform an intraoral evaluation, no different than what you do in a normal hygiene check. We're going to walk through that intraoral exam from an airway perspective. And if you're a hygienist on this call, we're going to show you how not to hate me and how to add just a few seconds to your visits to make sure that you have what you need to start the airway conversation. If the patient is not at risk, then we can just note that in our documents or notes, make sure that we say we screen the patient, they're not at risk, and we're done. If they are at risk, well, then at that point, we need to mention and recommend the home sleep test. I do recommend that you have a home sleep test code or a screen positive code inside of your patient management system. And from there, we either say, yep, the patient said yes to the home sleep test, or nope, they did not. And we're going to escalate to the doctor. There's another little row down there. We'll go through that in our actual demonstration today, but we're good to go. I did have a question here before we get into our subjective screening. Actually, I'll leave this up for a moment so those of you who need to scan that QR code can get it. How to calculate how many years the treatment for moderate to severe apnea can add to a person's life, say 20, 30, 40, 50, 60, 70 plus. The number 10 years for a moderate apneic is based on a pretty widely renowned study. I believe there's 2 studies coming to mind, and I don't remember which one it is. So it might be the RAND study on longevity of life and sleep apnea, or it could be the Wisconsin sleep cohort. If you haven't had a chance to look up the Wisconsin sleep cohort, I highly recommend looking into it. It's the longest and probably last longitudinal study of patients who go untreated for their apnea. I think we've raised some ethical concerns with that approach now, but it shows that patients who have moderate to severe sleep apnea on average lose between 10 to 20 years of their life if untreated. And it shows that they died 10 to 25 years earlier than people who had either less severe or no apnea. Really impressive study, follows patients with apnea for almost like 30 or 40 years. Very, very interesting. Again, that's the Wisconsin sleep cohort. If you need help finding these studies or anything like that, please send us a message or message us on social media. Our team will get you a copy of that study. All right, so that's how we do it. That's the overview. That's what we have to do to get to the result of a home sleep test. But how do we do that? Well, we said it starts with the front office. So what starts with the front office? Well, we got to talk to the patients. We already do this. This is something I believe that most dental professionals are really good at. They have the ability to spot these things in conversation. Now, not all of these things, to be clear. This is what I like to call the mostly great conversation starters, unless you're really brave, in which case all of these are really great conversation starters. We have the opportunity to talk to people if they're struggling with their memory. Some people, especially come January 1st, are talking about how they're excited to go to the gym to lose weight. Maybe they're talking about how tired they are or how drowsy driving is impacting their life. These are things that we talk about with patients, and they come up with the medical history. So if these things are in medical history, they become great conversation starters. Again, maybe not all of them, but most of them. Additionally, we want to talk about snoring. We've got to understand that snoring impacts our world a lot. The average snore is between 60 and 90 decibels, somewhere between a vacuum cleaner and an alarm clock. If you slept next to an alarm clock that went off, for me, 20 times an hour, every 3 minutes, you'd probably punch him in the ribs or her in the ribs. Hopefully not. But you guys get it. Snoring impacts relationships today. It's also part of the reason we know that the people who snore the loudest are the first ones to fall asleep because they're struggling, likely undiagnosed sleep apnea, or maybe just untreated sleep apnea. And it's also impacting their relationships in a multitude of other factors. So beyond those conversation starters, beyond snoring, let's look at this study by ResMed. ResMed did a study, and it was more of an analysis that looked at studies and pulled out the prevalence of sleep apnea with certain comorbidities. To be clear, this is not a study about causation. This is a study about correlation, okay? This is a study that says that these diseases showed up X amount of time for sleep apnea patients. There's no causation here. So all hypertension, 37% of patients who had hypertension also had obstructive sleep apnea. Let's jump up a couple. 72% of patients who had sleep apnea also had type 2 diabetes. 77% of patients struggling with obesity also had obstructive sleep apnea. And then last but not least, 83% of patients, 8 out of 10 people who had obstructive sleep apnea had 2 or more medications to manage their high blood pressure. Real quick, if you don't mind, in the chat for me, just so I make sure that you're awake and paying attention, remember there's no sleeping in a sleep training. How many patients out of 5 or 10, write it as a fraction, how many patients out of 5 or 10 do you see every day who have one of these 4 comorbidities that I listed off? Hypertension, type 2 diabetes, obesity, or drug-resistant hypertension. If you've got 4 out of 5 patients and you're not talking to them, that's a problem. And we're going to show you how to fix that in just a second. How many patients out of 5 do you see every day who need to have one of those 4 signs or symptoms? While you're thinking about that, thank you, Sunny. We got 2 out of 3, 4 out of 10. Mindy says 5 out of 5 patients. Wow, Mindy, you've got, I don't want to, it's not about the money, but you got a gold mine there. We got to go help some folks. Yeah, we're looking at 2s and 3s and 4s and 5s. Yes, we've got lots of people who are coming in who need these conversations to be had. With that said, I'm going to say this. This is something of a controversial opinion, so I apologize in advance, kind of. I have 2 forms on the screen. One is really, really small. There's a reason for it, but I have to talk about it. One is called the Epworth Sleepiness Scale. I'll talk about that in a second. It's one of those popularized screening forms in the sleep community. The other is a part of the Awaken to Sleep screener, just a proprietary screener we developed, and we use a very widely used screening form in the sleep medical community. And I'd encourage you to actually go through this real quick. On the right-hand side, you see yes or no. Have you ever been told that you stop breathing while asleep? If yes, you get 8 points. The next question, have you ever fallen asleep or nodded off while driving? If yes, you get 6 points. While I'm talking, go ahead and answer yes to those questions, and then go ahead and put your score in the chat for me. Again, more participation. This is also a great way to see if you need a home sleep test, okay? Why is the Epworth small? Unfortunately, while the Epworth is one of the most widely accepted forms in the medical and insurance communities, studies have shown that it's not correlative for women. So when men take this study, they actually, the scores translate to the risk. So if you score over the threshold, then you actually are at risk for sleep apnea. For women, women score too low, too frequently, and their scores do not correlate to the percentage of people diagnosed. And as such, it's become my opinion, and this is just one opinion of one sleep coach, that the Epworth is something of a form that if you have to use it, go ahead, but it really does have a sexist argument, unfortunately. And so we prefer other forms, and I'll be honest with you, I only prefer forms for teams that require forms to start conversations. Between medical history, subject of complaints, and our intraoral signs, which we'll talk about in just a moment, there's more than enough material for us to start an impactful conversation for our patients. So, what did you get on this score? For me, I got 34 when I first took this test. I said yes to all but 3 of the questions, getting a 34. Again, you don't want a high score here. But for this, I love this verbiage because you can say to your patient, you're moderately at risk, you're high at risk, or you're severely at risk for an airway problem. Remember, we don't talk about sleep apnea until we have a diagnosis. From here, we're going to be going into our hygiene conversation. Now, don't get me wrong, everyone has a role to play. Front office, we need your help in identifying those with medical history. We need your help. If you hear of anything in the lobby that patients are talking about, we need you to talk to us about that in the back. We need you to tell us that something happened that we should be talking to them about. But hygiene, you have the best relationship with our patients. You are the ones who, frankly, you see your patients more than they might see their mom or their dad or their mother-in-law. And that's a relationship that we get to really lean into because you are seen as a trusted advisor. And so we want to make sure that we understand that relationship and that we, like I said, we lean into it because we really want to save these people's lives. I didn't go through it, but chances are if you're here, you know the seriousness of treating sleep apnea. Excuse me. So when it comes to this, we're going to be doing this patient-centric screening, which allows us to start these conversations in a meaningful way. But before we do that, we've got to identify the things we're going to be talking about. And that's going to happen in part with our intraoral exam. All right. So what do we look at? Well, first we look at the intraoral crowding. A lot of sleep lecturers will say that an airway is like a box. If we put too much stuff in the box, then we're not going to be able to have air pass through the box. And as such, we know the box is crowded. If the mouth is the part of the box or is the box, we look and we see, is the soft tissue large? You can see white lines are enlarged, yellow are normal. And the question is, can air easily pass through this? For this, it's the reasons, a great observation here is that surgeries that are often done to reduce the crowding intraorally are things like tonsillectomies. You've got the laser therapy to remove parts of the tongue and a uvulectomy. These are surgeries that just make the box bigger or make there be more space in the box. And so this is one of the things as a dental professional that you're already there. Take a look. How crowded is it? And if it's crowded, mark that down as a concern. Here's a bigger list. We're not going to go through all of these today, but it is something for you to consider. There's data and studies galore on all of these different pieces. You can take a look and look up macroglossia and sleep apnea, and you'll find that there is correlation. We don't have a lot of causation studies at this point in time, but we know that when we see these signs or symptoms, that we often see sleep apnea to a high degree. We'll talk about some of those degrees in just a moment. Okay, keeping on. First intraoral sign we're going to dive into is acid reflux. Now, we see yellowing on the tongue here. What we're going to do if we see yellowing on the tongue is I recommend you warn the patient, unless you don't like them, in which case it's your prerogative. We're going to lightly scrape the top of the tongue. If the yellow residue comes off, that means that your patient has residue on their tongue. This is not acid reflux. This means that right before their dental visit, they went to a coffee shop, had a cream-filled donut, maybe a really nice Americano from Starbucks. And this is just the leftover residue from whatever snack they had, hopefully that day, unless they forgot to brush their teeth before the dental visit. But that residue comes off the tongue. There's a little rhyme to help you remember. Residue means they were thinking about you when they came in just having ate right before their dental visit. If you scrape the top of the tongue and it is stained, that means that it's acid reflux. See, when an apneic event occurs, it typically occurs in the posterior hypopharynx, right around here. This causes pressure to build in the esophageal sphincter. When pressure builds in this valve, it causes the valve down here, the esophageal sphincter, to weaken, allowing acid to enter the airway, crawl up, and stain the tongue. And so for adults, not children, for adults, acid reflux is the byproduct of sleep apnea. In children, it's actually the opposite. We see that acid reflux causes sleep apnea, but that's a whole nother lecture. Another indicator is bruxism. 70% of patients who I apologize, I'm stuttering and forgetting my stats. 70% of patients who did a home sleep test and had bruxism also had obstructive sleep apnea. 7% of people who grinded their teeth also had sleep apnea. When treated with a night guard, 50% of those patients had worsened apnea. Now, this was done with a flat plane occlusal night guard, and there's a lot of speculation as to what caused the worsened apnea in those patients. But the reality is that when we see grinding, we need to investigate to see if the grinding is a primary or secondary condition. That means, is it a result of a collapse of the airway and the body alarming the mind, alarming the body, sending adrenaline, causing the teeth to grind, which then causes bruxism because of the apneic event? Or is it just grinding? Is the grinding primary or the sleep apnea primary? Trust me, you'll want to find that out. You'll be surprised how many patients you resolve the grinding by resolving the sleep apnea. For this, please make sure moving forward that you always rule out airway as a factor for their grinding. This will protect you from any liability, and it'll make sure that you serve the patient best. There are plenty of appliances dual rated for both, and you can make sure to get them the most therapy for both conditions. The same mechanism that causes that bruxism, that grinding, is a scalp tongue. The tongue is pressed against the back of the teeth in a way to attempt to relieve the airway of the collapse. And so with this, when we see these impressions, that is a telltale sign that there's an airway issue. Otherwise, there's something else in the brain causing their tongue to be thrust into the back of their teeth with enough force to leave lasting impressions. Again, we've got to ask the question, why is our body doing this thing? It makes a lot of sense when we're looking through the lens of an airway concern. The next one is a high vaulted hard palate. We're not going to talk about different surgeries for this or options for this. There's a variety of different options, but the reality is if the box of the airway is small, then we just ruled in that this could be an airway issue. It's one of the reasons why orthodontics in children to really make sure that the development of the craniofacial structures is so important today. So just be on the lookout for that. The last one is tonsils, the last one we'll cover today. Tonsils, I can't skip tonsils. For me, I had a tonsillectomy, and it basically treated my apnea entirely, dropped me from a 23 all the way down to a 3 or 4. And here, that bottom right photo is what we like to call a great referral. It's someone who could benefit from an appliance, no doubt, but it's someone who really needs your help. It's someone who really needs, who likely is struggling with being sick all the time, tired all the time, snores all the time. An appliance can help them as a temporary measure, but they probably need to get those tonsils cut out. And so looking at tonsils, if you see large tonsils, let them know. See something, say something, I think the saying goes. So we start to get this picture of the intraoral signs. We see bruxism, tonsils, GERD. We didn't talk about the Mallampati, but the Mallampati is a very quick evaluation where we have the patient sit upright, stick out their tongue over their lips like this. Okay. And from there, we look at the distance from the soft and hard, from the tongue to the soft and hard palate. Based on that, class 1 patients and class 2 patients, we can see a lot of room in the back of their mouth. We can clearly see all the soft tissue structures. Those patients are considered not at risk using this evaluation tool. Class 3 and 4 are considered moderately at risk. Now remember, just because one screener doesn't catch them doesn't mean they're not at risk. It means that they're not at risk based on this screener. So we've gone through a lot. We've gone through our medical history, our subjective complaints, our intraoral signs and symptoms. I want to pause here for just a moment and ask, are there any questions, comments, concerns, or cries of outrage? Yes, that was just an excuse for me to take a drink of my coffee. So let's move on. We're going to take a quick second to look at a quick video, and then we're going to jump into our screening protocol so you can see exactly how we teach practices how to do this. Keep in mind, before we move on, one important note is that patients who have more than 2 signs or symptoms, then 1 medical history, 1 intraoral sign, 2 intraoral signs, 2 medical histories, 1 subjective complaint, or 1 intraoral sign. Any 2 indicators that they are considered at risk for an airway concern, that patient needs to be given a home sleep test. No ifs, ands, or buts. We're going to talk about what to do when we find those 2 signs or symptoms in just a moment. But first, go ahead and pay attention to the screen.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's gonna stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever gonna stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way. Do I have to keep on talking till I can go on?
All right. It's not about the nail. It's so important that we watch that video, because if we go to our patients and we say, hey, Mrs. Jones, you're broken. In fact, you've got sleep apnea for sure, and here are the 15 reasons why. We need at least 2 signs or symptoms for them to be categorized as at risk. But after this training, you're going to see 5, 6, 7, 8, 9 symptoms at a time, and take it from personal experience. You don't want to be in a position where you are talking to patients about the list of things that are wrong with them, really anyone for that matter. Don't do this with your wife, your girlfriend, your friends. It will never end well for you. And so to demonstrate our protocol, what we're going to do is a little role-playing exercise. And so what's going to happen right now is I'm going to show you how this works in a dental practice. What's going to happen is when I'm on this side of the screen, I'm going to be Dr. Smith. When I'm on this side of the screen, I'm going to be Chad, the hygienist. And when I'm here in the middle, I'll just be me. A couple things for you. When I do this, it means action or cut, depending on what I'm doing or not doing. And we're going to try this as best we can. Now, you should know one disclaimer. in college, they required I take an acting class, one of those GE requirements. And the rule was it was a 1 credit class. You had to show up for 2 days. That was it, 2 days, 2 Saturdays for like 5 hours each day, and you got it. And the teacher, I showed up to day one, not particularly excited. Teacher said, look, not all of you are going to be actors. In fact, most of you will not go into acting or theater of any kind. As such, if you show up to both days, you will pass this class. If you don't, you won't. I said, done. Here I come. Well, get my report card at the end of the semester, and I failed the class. I go to the teacher and I say, hey, this is what you said. What the heck, man? He said, what are you talking about? I've never seen you before. So it should be a lesson to everyone here. I am not a good actor. I failed an acting class where the only assignment was to show up, and I was so bad, he removed me from his memory like a traumatic event. So just know that as we do this, yes, I'm going to be playing a couple different roles. No, it's probably not going to be a spectacular performance, but you know what it will be? Incredibly practical for your team. So take notes. We've got copies of this script. If you want a copy of it, just let us know. We can send it over to you, but we're going to jump into this real quick. So first up, our patient today is Mrs. Jones. Mrs. Jones is just the sweet, not old, but not young lady, kind of retired early, has some grandkids, salt of the earth kind of people. Despite our protest, she brings a pan of brownies every time she comes in for a cleaning. And even though we do protest and say how bad it is that we shouldn't eat sugar as a dental practice, that pan of brownies leaves completely empty every single time she leaves the practice an hour later. Mrs. Jones has come in and our office has just been trained on airway. And so we make her fill out a handy dandy questionnaire for her medical history that has a couple updated questions. And as I'm front office person, I'm noting right out of the gate that maybe she has hypertension. We've known this, but now we're looking at it a little bit differently. As Chad, the hygienist, is walking her back to the hygiene chair, I do see the medical history note from the front office. She also tells me that lately she's been struggling because she's been feeling tired. And that's been an issue because she drives her grandkids home from school every day. And in order to feel completely alert when driving, she's had to have an extra cup of coffee. And while she doesn't mind the coffee, she minds that she has to lean so heavily into it to feel awake and alert enough to drive the grandkids. Then we sit on down to the hygiene chair. As a hygienist, I say something like, hey, Mrs. Jones, real quick, I want to do a quick oral exam just to see how everything looks. She opens her mouth. I see what we've already known in the past, but now again, we're looking at it with different lens. We see her bruxism. We see a little bit of tongue scalloping. We see some yellowing on the tongue. And that's just kind of where we're at. At that point, as a hygienist, have a decision to make. What do I ask or talk to her about? Real quick pop quiz. How many signs or symptoms of an airway concern did I find with Mrs. Jones? Go ahead and put your answers in the chat. I am looking at the chat. Let's count. We have hypertension. We have daytime fatigue. We have bruxism, tongue scalloping, and acid reflux. Yes, Daniel, you are correct. We have 5 signs and symptoms that we identified for our patient. So what we are not going to do is go through all of those. Hygienists, dental assistants, doctors, please hear me loud and clear. When we talk to these patients, we are going to pick at most 3 signs or symptoms. 3 at most. No one wants a laundry list of things that are wrong with them. Remember, it's not about the nail. We need to pick the 3 most impactful pieces of information that are going to help the patient move from their current frame of mind to the next frame of mind, which is that we need to take a home sleep test. Okay, so hygienists, doctors, pay attention. I'm gonna show you right now what the hygienist does so that you guys can see exactly what that looks like. So, hey, Mrs. Jones, I'm a little concerned about your airway. Based on the fact that you were talking about some of this drowsy driving that you've got going on, based on the bruxism that I know we've talked some about and we haven't really found a solution to, and then also on this hypertension, I know that's kind of been an annoyance for a little while. I really think airway might be a factor, and I'd like you to do a test. What do you think? Real quick, you guys have this really handy dandy raise hand button. If you don't mind, go ahead and raise your hand to this question if you think you can do it. Tom, you are on it. Thank you so much. Who thinks that their team can do that? Thank you. We've got 3 people on this call, 4, thank you, Rachel, who think their teams can do that. Again, all we're doing, just to clarify, is we're going to say 3 signs or symptoms that are most concerning, and then let the patient know, I'm concerned about your airway, and I think you should do a test. Awesome. We got a lot of you folks who are here thinking their teams can do it. That's it. Now, what's going to happen is the patient will either say yes or no. If the patient says yes, fantastic. We can put that in their chart. We're going to give them a home sleep test today. Now, depending on your workflow, your office, your situation, you're either going to hand that out to them at the front desk, or you're going to use a service like sleeptest.com or one of those third parties, and you're going to have them, go that route. It doesn't really matter. We want to get a yes to the test, and that's the most important thing we're going to do. If the patient says no, for my more sensitive offices, if your hygiene can't handle that, then probably give them some space. I'm just kidding. Hygienists, man, dental professionals in general, you guys have a lot of friction in our nose that happen because patients don't want to fix their problems, because dental, for some reason, is seen as less urgent than some medical thing. It's bonkers, but those are not something we're not unfamiliar with. So if the patient says no or no thank you, then great, just move on. The hygienist is going to continue on with her normal scheduled program. Clean the teeth, do the bit, whatever the normal situation is, the hygienist is going to do all of that stuff. Later in the appointment, the doctor's going to come in, and for most practices, what's going to happen is we're going to see the doctor come into the appointment, and their hygienist and doctor are going to talk about the signs or symptoms of the dental exam. So it might look something like this. Hey, Dr. Smith, so I was talking to Mrs. Jones, and I couldn't help but notice that there was some pain on number 6. Number 9 looks like it has a cavity, and number 47 doesn't exist. And Dr. Smith is like, 47? Okay, we'll talk later. Yeah, all right. Number 6. Yeah, that's kind of an ugly tooth. We're just gonna, all right, fix that up. Yep. And number 9's cavity. We can just do a filling. We'll call it a day. I don't know. I'm not a dentist. I never pretended to be beyond this role-playing exercise. So dentist, you do the dentist thing. That's your job. You're going to do that. At the end of your dental exam, dentist, please listen, pay attention. We're going to do another raise hand thing in just a moment here. You're going to do this very simple but critical verbiage. Okay, here we go. I'm going to clack. We're going to pretend I'm the doctor. Remember, on this side of the screen. Ready, set. Chad, is there anything else we need to talk about? Real quick, doctors in the room. Who can do that? Give me a thumbs up. Give me a hands up. Give me a holler. Yes, we got a hand up. We got a thumb up. Yes. All right. You guys think I'm joking? I'm not joking. Patients need to see you switch roles. You finish the dental conversation, and you're going to come in and say, is there anything else we need to talk about? The patient is thinking, anything else? We just finished the dental conversation. In their mind, they're now transitioning to the different conversation. They're looking at you, the dentist, not as a dentist, but as a healthcare professional, because something else is going on. That's why we have to say that. It is really important, and I promise you, you implement that little verbiage trick at the end of your dental consult, you will see an uptick in your conversions. All right, here's what's going to happen. We're going to say, is there anything else we need to talk about? This is what happens next. How am I going to do this? Okay, here we go. I'm going to clack as the doctor, and we're going to go real time. I'm going to switch roles, and you guys are going to see what I recommend the hygienist do. I'll break it down in just a moment. Or lower all your hands because we're doing another one of those hand raising exercises. You guys are doing great at the hand raising. Thank you very much. All right, ready, set. Is there anything else we need to talk about? Doc, I was talking to Mrs. Jones, and I couldn't help but notice from our conversations and just some of the notes in her account, she had mentioned some drowsy driving, fatigue, the hypertension, that bruxism we've talked about in the past. And I'm really concerned about her airway. I was really hoping you could talk to her about that. Hygienist in the room, doctors of hygienists in the room. Who can do that? Give me a thumbs up, give me a hands up, give me a holler. What did we do exactly? We did a pregnant pause. And no, we're not talking about 6 to 9 months. We're talking about 3 to 5 seconds where the patient held their breath. All right. No, I'm sorry, the hygienist. Now, listen, this is an intentional method of communication. That's what we're doing. Think about it. Whenever we've gotten bad news, right? If you had to do a breakup, if you go to the doctor, right? Go to the doctor. Chad, we can't fix stupid. Whatever it is, we have the bad news followed by that pregnant pause. If you have kids, you know yelling scares them. The pregnant pause scares them more, okay? When we look at this dynamic, we can see that we can communicate intentionally and get to the heart of the issue. Guys, I said this earlier, I'll say it again. If I had gone untreated, I would have lost 7 to 10 years of my life. I'm asking hygienists to pause and wait 3 to 5 seconds, heck, 2 to 3 seconds, so that we have a better chance of saving 7 to 10 years of their life. I think that's a pretty good trade. So, well, what do? We do a pregnant pause, and then we state the same 3 things, that's very important, the same 3 things to that patient in front of the patient. That's what we're going to do. I'll do a recap of all this in just a moment, I promise. At that point, doctor, what you're going to do, the hygienist says their bit. Doctor, I want you to look at this patient like you've never seen them before. You've taken off the dental hat, you've put on the sleep medicine hat. Look at the patient like you've never seen them before. Hey, Mrs. Jones, real quick, can you open up? I want to take a look at the bruxism. Yeah, okay, yeah, we have talked about that before. Tell me a little bit about this drowsy driving. Okay, it's just in the afternoon okay, great, no problem. Mrs. Jones, patients who exhibit the signs and symptoms like this, patients who have the bruxism, the hypertension, as well as the drowsiness and the fatigue that you're experiencing, they're at risk for an airway concern. And the next step is for us to do a home sleep test. I put one in your treatment file. We have one here in the office I'd like to get you set up with. Do you have any questions for me? Doctors, give me some thumbs up, give me some hands up, give me some hollers. What are we thinking? How we feel about that? Is that something you can do? And while you're thinking about it, I want to emphasize something. A patient comes in brand new to the practice and they say, I know I'm new here, but I don't need any cavities. I don't have any cavities. I don't need any restoration. I'm actually really good. And you're like, well, have you had an x-ray? No, I don't need one. Well, why? What do you mean? Like, I don't need an x-ray. I don't have any cavities. Well, how do you know that? Well, because I don't. Because you guys get what I'm saying here? You can't tell someone that you don't have sleep apnea unless you do a sleep apnea test. Okay, that's required criteria. The same thing, if a patient presents pain, if they look like they have decay, the next step every single time, and I mean, I guess not every single time, but most times, is for them to do a x-ray. There might be a cone beam depending on your practice and whatever. But the next step is to get an image of the potential issue every time. I don't think anyone here, and if you are one of these people, I'll lower everyone's hands. If you're one of the people who would be very hesitant to recommend an x-ray, you can raise your hand and prove me wrong. But in my experience, working with dental professionals for over 7 years, if there's ever an image that's needed, it's never even been like, if a patient says, I don't think so, like I don't agree with your need of an image, the experiences I've had were like, what? What do you mean? Like, that's what we do. I can't help you if I don't have an image. That's how we need to treat sleep apnea tests. Home sleep tests are just like that. If you go to a hospital, if you go to a sleep center, if you go anywhere and you show these signs or symptoms, the next step every single time is a home sleep test. Even if you present neurological issues, they're going to require a home sleep test because medical insurance won't pay for an in-lab test without a home sleep test, with very few exceptions. So the next step, if they're showing signs of an airway obstruction, is a home sleep test. So doctors, that verbiage is really important to say, yeah, the next step is. Their feelings are almost irrelevant. Again, we've done our best to do that, but you're the expert in the room, and that's what we got to do. Haley, I'm going to come back to your objection. Thank you so much for putting that in there. I'm going to offer this right now. Go ahead and put your objections in the chat right now or the question and answer section. I will answer as many objections as we have time for today. I'll even stay late to answer objections to those of you that want to hang out today, okay? So that's what we're going to do. Real quick, let's go through the entire recap from start to finish. You guys ready? We're going to do the 2-minute version of that training. Patient walks in, medical history. We note that they've got a concern on their medical history, hand them off. Hygienist hears that they've got some subjective complaints. We do an intraoral exam. We find 1 to 7 things wrong with them. We let Mrs. Jones know, hey, Mrs. Jones, I'm concerned about your airway because of 1, 2, and 3. I really think you should do a home sleep test. Mrs. Jones says, no. Cool, no problem. Let's continue on with our cleaning. Clean, clean, clean. Great. Doctor comes in. Hey, Chad, anything we can talk about that we need to help the patient with today? Hey, Dr. Smith. Yep, it looks like we've got 1, 2, and 3 issues with the mouth. We got a cavity. We need a filling. We need a root canal. I don't know. Whatever. Great. Well, Mrs. Jones, we can fix your dental work. Basically, we just dunk your head underwater and call it a day. We'll be done. I'm just kidding. Chad, is there anything else we need to talk about? Doc, I was talking to Mrs. Jones about her airway. Based on the fact that she's got 1, 2, and 3, I'm really concerned, and I was hoping you could talk to her a little bit about that. Mrs. Jones, patients who exhibit signs and symptoms such as 1, 2, and 3, the next step is for them to take as a home sleep test. We've got one here in the office, or we work with a third party that can get you one directly. Do you have any questions? They can get you set up in the front with that. Questions, comments, concerns, or cries of outrage, put them in the chat, put them in the question and answers. We've got a couple more slides to wrap up the night tonight. That is what we call the 3 favorite things protocol. And what we're going to be doing with it is we're going to be making sure that our patients get help, because that is what they're here for. That's what we need to do. So with that, we already had one of these put in the chat. Tonight, we have limited amount of time, but the missing puzzle piece that we have is objections. Listen, the month that your team implements this training, which is recorded, so great. You guys have the ability to give your team this recording to make sure that they get everything they need. They can see my goofy exploration of the protocol. They can see the signs and symptoms, 100% of it. If you thought the jokes were bad, just fast forward on those parts, okay? But you're going to run into objections, and that's great. I want you to know that's required. If you want to see success in sleep, you're going to have to run into objections. So we have an objection handling training on our website completely for free, just on objections. But we just released this tool. Scan the QR code, enter your name and your email so we can send you your objection handling script and tell us what patients are telling you that's wrong or not working. You can submit it a handful of times. We'll give you a bunch of custom scripts. I think our limit is up to 3 actually, so just don't go crazy, okay? That said, I want to point out it does ask for a phone number. We do that in case you want to talk to a coach on the phone. Notice it's not required, so you do not have to give us a phone number. But if you tell us what's wrong, our team will look at your objection, and just like this video showed, it will actually show you the context of why the patient's likely saying that, and give you specific verbiage for your team to use, a script for your team to use to actually go forward and get people through that objection. So scan the QR code, forward that to your doctor, forward that to your team. Let us know how we can help you. Again, if you have objections, we're here to help out with that. Haley said, what if the patient says, well, I don't snore, so I think I'm fine? Well, good news, if with the demonstration I just shared, I didn't even talk about snoring. In fact, I try not to talk about snoring because patients think that snoring is the issue, and it's not. Sleep apnea is the issue. Airway is the issue. Another component for snoring is that we see that patients are kind of identified as snorers. If you think about it, a lot of people talk about snoring like, oh, I'm from a family of snorers. This is just what we do. We snore. Yay. Definitely not okay. definitely just a thing that people think and say. So for that, I try and stay away from snoring whenever possible. That said, if you're going to talk about snoring, then one of the verbiage tips that we have is that you've got to make snoring seem out of place. And you have to do that without telling the people that they are out of place. So some verbiage that we've worked with in the past is patients who snore have often found that there's a more serious problem going on. In fact, studies show that snoring isn't normal, and snoring is most typically related to an airway issue. The sound of snoring is actually you struggling to breathe. And so we like to evaluate the airway just to make sure that snoring is just snoring. If you don't snore, guess what? The test will show that you don't snore. Unfortunately, the test also makes a liar out of a lot of husbands. So I would recommend that you do it. If you want to have some real fun and your doctor approves, bet the home sleep test. Our home sleep test is $250. If you don't snore, you can have it for free. You pay me up front, I'll refund you. Chances are, if the wife says they snore, you're going to win that bet. But here, if we can avoid snoring and wait, we pretty much won that battle. Haley gave another objection. My clenching and grinding is from stress. Again, I'm not a great actor, but the number one rule of improv is yes and. So, Haley, I would say to that, yes, you're probably right. If I'd have to venture to guess, the stress is made worse by the fact that your body is literally stopping breathing at night. But we need to see if the airway is a factor, because it could be that your stress is made worse by something going on in your airway. We see that stress is raised significantly in folks who have a hard time breathing in their sleep. So I think we should just rule out that airway is a factor to make sure that we've got all the correct picture. Again, we're always ruling out that airway is a factor. Again, we're not saying sleep apnea because no one has sleep apnea. Just ask them. Awesome. Thanks, Haley. I'm glad that you love it. That's awesome. Again, if you have questions, comments, concerns, cries of outrage, or objections to anything, this could be your team, this could be your patients, make sure to put them in the chat. We're about 5 minutes away from wrapping up, so we're going to be transitioning to the question and answer session. If you have objections, last chance to scan this QR code. I will also send this in the message at the end of the night. We'll also send this in the email come tomorrow. One last thing, you may have heard about our Business of Sleep Dental Sleep Medicine course. This is going to be an amazing event. We're talking about things like verbiage. We're talking about workflow. We're talking about teams. I gave you a small inkling of what some of that looks like, and we are just about sold out. In fact, we had to go back to the hotel and say, hey, we need a couple more rooms because we had people asking for rooms. So here's the deal. We have 3 rooms left for the event, 3 rooms that we had to go get from the hotel for people who want to come to this event. Please do not wait. If you want to register, we're about sold out. You can scan the QR code, go to the URL at the bottom. We are bringing the best of the best. Stacey Lehman, Lisa Crawford, Kent Smith, Dr. Harmandeep Singh, folks who are, well, the best in the dental sleep medicine industry. If you want to grab your spot, please make sure to do so. More than that, if you want to talk to a coach, you have questions, comments, concerns, or my favorite, cries of outrage, please make sure to schedule a call with us. We want to help you. We do these webinars because we want to serve the community. We do these webinars because we want to make sure that people are being helped in your community. And tips like this workflow tonight are things that are battle tested. I showed you the results of this training earlier today, and it works. It matters. So with that, I'm going to grab the CE link for those of you that are still hanging around, and we'll stick around for another couple minutes while if there's any questions, comments, concerns, and we'll go from there. While I'm grabbing that CE link, is there anything else that I can help you guys out with? All right. CE link is, oh, we do have some questions. Cool. For those of you that need to go, oops, well, might help if I post it to everyone. Your CE link is in the chat. I'm also going to be putting in these other 2 links for you. Okay. Oh, right. And the last one, actually, I apologize. I'll put this in here. I do have one question. The rest of you are free to go. The objection handling script is also there. The question is, what home sleep test do you recommend? I recommend the home sleep test that your office is going to like the best. There are tons of home sleep tests in the marketplace. There's less now, but you can do something like a Knox T3. There are rings out there. There are Z machines. They've got some really cool technology. It really depends on the data that your office wants. There has been discussion about certain rings not having consistent data markers on the 3% criteria. So I would say do some research. If you want the most channels, the most bang for your buck, Z machine, it actually has the ability to be built out and done as a type 2 home sleep test, which is really, really awesome. If you want the coolest piece of technology that is also the most cost effective, the Knox T3, expensive up front, really cost effective long term. If you want the coolest Cadillac of home sleep tests, you could probably look into is blanking on that one. Oh, shucks. WatchPat, that's what they're called. A WatchPat 1 or the disposable WatchPats. Those are really, really cool pieces of technology, but they are pretty expensive. You end up doing about 100, 200 a test. Right now, we are seeing a pretty heavy leaning towards the Z machines, though. Cool. Any other questions? Does anyone want me to flip over to any slides that you missed? Awesome. Well, folks, thank you so much for joining us tonight. You are free to leave at whenever you want. I'm going to shut down this meeting in 1 more minute. Please make sure to grab your CE link. If you need any of the other links, like a coaching call, the masterclass, or your objection handling script, please make sure to grab that before we close out the meeting. We will email the recording again in 24 to 48 hours. Thank you so much for joining us tonight. We really enjoyed having you.